Okay, thank you. So we're going to move to case 2. Chiara can take a well-earned seat now. And I'm going to invite Mr. Hassan Malik to lead the discussion on the second case.
Thanks very much. So I think we're going to take it back a few steps. This is about this idea of an MDT, and really I want this discussion in the next 40 minutes to focus on the patients in the audience, because you and your loved ones would have had your case discussed at this MDT thing, and you've been told, they've said this. And at the end of the day, what is that MDT? How does it make these decisions? I'm not in that room when that decision's made. So, it's really to can explain that concept. Okay, so the MDT is essentially a decision-making machine. That's what it's about, fundamentally. And the idea of decision-making is reaching a judgment with whatever situation you're faced with. And that has a number of elements to it. So you need to assess that situation, then generate a few options. Hopefully there are options here. There certainly were many options for the advanced disease. You've got to select an option, and you hope that option was right. You certainly should review your outcomes and at some stage publish those outcomes, I guess, if you're a clinician. So this is the example of how complex that is. So this is a patient who presents jaundiced with a mass in the liver, likely a perihilar cholangiocarcinoma, and you can see the complexity of assessing, staging, management of jaundice, deciding what treatment options you've got, and then doing something about that. This happens in every resectional cancer hospital around the country, and every HPB centre in the country that does deal with these patients. Often in this MDT, you may have 40 to 50 cases to discuss in 2.5 hours. So every patient, you're talking about 2 or 3 minutes of discussion where that decision is made, and that's not a lot of time when it's someone's life at the end of the line. So anyway, this is a lady who presented jaundiced with some initially had some vague symptoms for a few months, and then became jaundiced, very jaundiced in fact, and had a CT scan which shows this. I'm going to try and run through that there. So essentially, to summarize that, what the patient had is an atrophied left liver, left portal vein, taking blood into the left liver was attenuated, but there didn't seem to be any obvious evidence of metastatic disease, which is hopefully good. So the first bit is this patient's jaundiced, so we need to try and save their life by dealing with the jaundice, so we want to focus on that bit. So let's see. So I'm going to pass on to Chris. If you've got your thing there, you can move the discussion forward.
Thank you, Hassan. Is that microphone? Yeah, it is now. So thanks very much. So I'm going to talk about preoperative biliary decompression. So my angle is always ERCP, but we'll also be talking about PTC, percutaneous transhepatic cholangiography, to manage preoperative biliary drainage. So our core option when our core objective, when we're trying to drain someone who's likely going to go forward for surgical curative resection for cholangiocarcinoma, is to relieve the jaundice and the itch. And the consequence of that is that we usually improve fatigue, patient's appetite, their nutritional status, and their performance status. And this is all important for successful surgery and to minimize post-operative complications. The level at which the bilirubin has to reach before we decide that preoperative biliary drainage is necessary varies from centre to centre. There are some surgical centres where patients will go forward for surgery if the bilirubin is less than 100 or less than 50 and go for primary surgery. In the real world, that's often difficult because a patient with a bilirubin of 100, you often find there's an accelerating deterioration in the following week or two, and 2 weeks later the bilirubin is 350 as they come for their preoperative blood tests, and their long-awaited, very precious operative date is then cancelled. So having arbitrary cut-offs and the perhaps ideal world aim for direct to surgery with relatively low bilirubin levels is often very hard to achieve. So typically if the patient has got clinical jaundice, they will have preoperative biliary drainage to permit them to be bridged to surgery, have successful surgery, or chemotherapy if they become a non-operative candidate. ERCP can also aid the diagnosis. So in indeterminate cases where the MDT is not confident that the right option is radical surgery, ERCP also gives the opportunity to gain further imaging information, but also importantly, histological or cytological confirmation of the diagnosis and confirm that resection for true malignant disease is necessary. And the final point that dropped off the bottom of the slide is that you can get some useful staging information from ERCP imaging, even when compared to MRCP imaging. It's often of marginal benefit, but it's a sort of a peripheral benefit of undertaking an ERCP. So in the MDT, when we're discussing a patient with obstructive jaundice from a likely hilar cholangiocarcinoma, the first thing that we have to determine is whether the patient should go forward for endoscopic intervention of biliary drainage, so via the mouth, stomach, duodenum, up the bile duct, or whether they should go for a percutaneous approach where the radiologists puncture the biliary tree through the skin and then pass a wire down the bile duct through the stricture and then place a stent or a drain of some sort. The third option, which isn't on the slide, Simon Rushbrook alluded to earlier, which is our ability now to use EUS and lumen-opposing metal stents to create a fistula through the duodenal wall into the bile duct and drain the biliary system that way. And that currently is regarded as typically a salvage procedure after a failed ERCP, but it's certainly proving very useful in that one procedure, normally under GA or deep sedation with an anaesthetist, you attempt ERCP. If it fails, you can switch to the EUS scope straight away and place a lumen-opposing stent through the duodenal wall and drain the biliary tree that way. It's only really an option, well, it is only an option in very distal cholangiocarcinoma, so it's most frequently used in head of pancreas cancers. But the very tentative data is that in pancreatic cancer, taking that approach does not seem to affect the ability of the surgeons to then undertake pancreatic resection in pancreatic cancer. And so it's a reasonable, if slightly stretching the point, assumption that it should be safe in patients with distal cholangiocarcinoma and not preclude subsequent surgery, but that has not been proven beyond doubt by any means. So the type of system that is then put in also varies. And this varies depending on the location of the tumour, the diagnostic certainty about what's going on, and also local expertise. And Simon touched on this earlier, and it's something, when we hear the oncologists presenting very, very clear multi-centre randomised data on drug treatments, we just do not have that data in these interventions. So we often allude to the technical expertise in the centre, and that is important. The reason, I think it's useful just to explain that perhaps some of the reasons why we don't have that data. And there are multiple factors in that. There's patient heterogeneity, there's technical heterogeneity in what different centres can do, financial heterogeneity, what is expensive in one centre is regarded as a completely reasonable cost in others, either within a country or internationally. And an important factor is the funding of studies of these techniques, in that drugs and drug companies are required to have extremely high-level data to confirm not just safety, but also efficacy before they can launch that product and achieve approvals. Whereas these techniques, all that the manufacturer producers have to do is prove that it's biologically safe. The device itself is not going to kill the patient, and then they can launch that product. And then those products get adopted. People publish case series, then they try and do a sort of case control where they try and pick an approximate control group to match with their cases. They publish it, someone picks three of those up and does a meta-analysis, someone publishes 2 more, and then someone else does another meta-analysis of 7 or 8 studies that have now been done, and that's the literature body that then gets used to try and guide what we do. So I just touch on that as a sideline, because I think it's just important to set the context of why we're always quite woolly about these decisions. So advantages of a percutaneous drain are that the patient can often get away with much lighter sedation. If they've got respiratory compromise, it can be easier. And there is some limited data that, particularly for hilar lesions with separation of the right and left ducts, so separate obstruction of the right and left ducts, that adequate biliary drainage can be more successful. Disadvantages are that the bile leak rate is quite high, post-procedural pain is higher, bleeding is higher, and the number of procedures tends to be higher. And the patient ends up with an external drainage system, which can be quite difficult and unpleasant to manage. Other options are the ERCP. Disadvantages are that there's a high rate of pancreatitis, which is, if it happens to a significant degree, is an appalling complication to have, particularly in a patient who is being planned for surgery, because it will definitely put that operation date back, and it may knock their performance status so far that they never reach surgery. So that's probably the main downside of ERCP. ERCP, though, often is a single procedure, and it's a fully internal system, so the patient doesn't end up with external drains. Another discussion that goes on at the MDT is whether to use a plastic or metal stent to try and maintain drainage if we're not going to use an internal-external drain paced by the percutaneous route. And that tends to be dictated by our certainty about the location and the nature of the tumour. And that leads on to the next step, which is if we're going to use a metal stent, do we use a covered or an uncovered metal stent? Because covered metal stents are removable, uncovered metal stents are categorically, effectively not removable. And if you put an uncovered stent into benign disease, or disease which is likely to be highly chemosensitive, like a lymphoma, it can be a disaster, and you can end up with that patient being cured of their underlying cancer or having benign disease, not cancer, and coming back with complications of that stent for 10, 20 years thereafter and causing significant morbidity. Another decision for the MDT is what the anatomical target is. Where is the lesion and which part of the liver do we wish to drain? And certainly now there's a pretty uniform acceptance that unilateral drainage of the side of the liver that is going to be retained post-operatively is the target. And that will normally be obvious, but it will also be specified in the MDT meeting what route we're going to use, what sort of stent we're going to place, and whether we're aiming for bilateral drainage or unilateral drainage. The important thing just to mention there is that, and it goes for, I think, all of the decisions that are made in an MDT, is that there's a sort of committee-based hive key decision-making, but individual consultants do still have to make on-the-spot decisions about what the right thing to do is. And for instance, during ERCP, if you're doing the ERCP, you're aiming to drain the right side of the liver, and you put a load of contrast into the left liver that doesn't drain, you would be criticised for not putting bilateral stents in to drain the left liver, and you'll be doing your patient a disservice. So all of these plans have to be flexible and modifiable by the clinician that's doing the operation or prescribing the chemotherapy or doing the ERCP. The final thing to mention on this slide is that it's a bit outside the purview of this patient, but we can do other things during the ERCP. We can get biopsies, we can get histology, and we can get those off to the lab for histological confirmation, but also to start the molecular profiling that we've heard is so important already today. We can do cholangioscopy, which can give, and I'll show some pictures in a moment, that can give really, really good pictures and confirm the diagnosis. And I've talked before at this meeting, and a lot of people in the room will be aware of, there are various ablation techniques, PDT or RFA, you can apply within the bile duct, but not usually in the context of a patient that's going forward for surgery soon. So these are some pictures from a standard ERCP approach. The ampulla is the little lump in the middle, and the middle picture shows a catheter now up the bile duct, and a small sphincterotomy has been performed to open up the bottom of the bile duct, and then in contrast injected, and we get an X-ray picture on the right-hand side of that slide. What we would typically do next is demonstrate the lesion, and this slide shows a case very similar to the case that Hassan's presented, though the pictures are from a different patient. There's a very tight stricture just above the level of the endoscope. You can see there's black contrast in the bile ducts above with a wire going up into the liver. There's then an absence of black in that stricture, maybe 2 centimetres long, 1.5 centimetres long, and then there's black below, this contrast below, with the gallbladder starting to fill. And what we can then do, and you can see on the right-hand picture, biopsy forceps going up, which allows us to get really good volumes of tissue. And from a hilar cholangiocarcinoma with 4 to 8 biopsies, you can generally achieve you can generally achieve, oh, thank you, there's a laser pointer, that'd be fantastic, otherwise this is going to go on forever, isn't it? You can, thank you so much. Yeah, and I better point at that one, not that one as well. So this is the stricture, and over on this side you can see biopsy forceps going up. And those biopsy forceps, if you take between 4 and 6 biopsies, you'll get over 90% histological confirmation of this being a cancer, if it is a cancer, and you will get an adequate volume of tissue to permit molecular profiling. That brush in the middle is a cytology brush, and even with the best of efforts, you will rarely get a positive specimen over 15 to 20%, even if you go at it for a prolonged period of time with that brush. So transpapillary biopsies or cholangioscope-guided biopsies are far better at getting positive histology or positive cellular confirmation of cancer. So these are just some examples of the stents we can use. On the left-hand side is a straight plastic stent, 10 French straight plastic stent, available in various lengths. And in the centre you can see some covered metal stents which have got a plastic sheath on them, which means that tissue ingrowth is mitigated and therefore they remain removable. And on the right is a bare metal stent, which you can pass over the hilum, you can pass over the cystic duct origin without blocking them, which means that you can traverse those areas without the risk of obstructing the contralateral liver or the gallbladder or the cystic duct. Just talking about stents in a little bit more detail, these are one, I don't even use the word, we shouldn't really use the word controversy, but this is what's open to debate. So in some centres, for a case like ours with a stricture where we're aiming to drain the right side of the liver, we know the patient's highly likely to go forward for cancer. If we don't have histology yet, in many centres, the choice would be to biopsy the lesion and place a plastic stent into the right liver to achieve biliary drainage, which should be absolutely adequate for their bilirubin to drop and then to go forward for surgery without placing a bare metal stent, which is not removable and may complicate the surgeon's life when they're doing the resection. In other centres, the surgeons and the MDT are more relaxed about the placement of bare metal stents, and if there is very convincing evidence that this is malignancy, a bare metal stent may be placed at the index procedure. In tumours that appear to arise below the bifurcation, so below the hilum, either just below or well below, selecting a fully covered stent gives you the benefits of the better drainage of a metal stent with the flexibility of being able to remove that stent if it turns out the patient had lymphoma or PSC or IgG4 disease, rather than having the disaster of a bare metal stent placed into benign disease. So this is a case very much like the lady that Hassan's presented, with a just about subhilar lesion where the wire is placed above, and then a metal stent has been placed above, achieving very good drainage. And there's actually continuity with the left side of the liver, so actually that's achieved drainage of probably the whole liver. And the patient will then go forward for surgery in a surgical unit where the surgeons are not put off by a bare metal stent, and we may discuss that with some of my surgical colleagues in a moment. It's not relevant to the case we're discussing now because our patient is likely to go forward for surgery, but in palliative cases where we know from either from the MDT discussion that we do not think that curative surgery will be possible, the aim is almost always for bilateral stenting when there's hilar obstruction, and that can be achieved either by ERCP or by PTC. As I already said, there are some small studies that suggest PTC has an advantage, but it still tends to be per local expertise. And this just illustrates the MRCP on the extreme left, post ERCP with stents running from the duodenum right up into the right and left livers, like right and left liver. And the reason I always mention this is having these stents extend right the way down is really useful if the patient then gets obstruction of those stents. And again, there was talk this morning about, stents being put in and then that's it. Now with people surviving longer because of all the great new treatments that we're seeing and the effects they're having, leaving the arrangement like this means that we can go back and we can access both of those stent systems independently. If there's ingrowth, we can RFA it. If there's debris, we can pull it out with a balloon. And this is going to be increasingly important. So stents that cross each other, such that you can only access one of them, or that don't extend down to the duodenum are going to make that very, very difficult. So here you've got both stents visible. You can selectively go up one or other of both of them and sort out any problems that occur 6 months, 12 months, 18 months down the line. This just illustrates a PTC approach. So this one shows that wires have been placed through both the right and the left liver, down through the stricture, and then stents have been deployed to achieve drainage from a percutaneous approach. And that's often a very effective way of achieving palliative biliary drainage in unresectable cholangiocarcinoma. But just to bang on about it, sometimes you end up with these stents crossing, which means you'll not be able to get selectively into both of those stents if the patient runs into trouble with obstruction down the line. So it limits what we can then do endoscopically to clear blocked stents, and it's likely that patient would require further percutaneous procedures if they run into stent blockage down the line. Just very quickly, single operator cholangioscopy is where we pass a tiny endoscope down the big endoscope and up the bile duct over a wire. And it gives us pictures like these of the inside of the bile duct. So on the left is a normal bile duct, and these are all pictures of cholangiocarcinoma. You can see neovascularization and this polypoid surface with contact bleeding, and there's not much doubting even looking at that before you even then do the biopsies. And bottom right, you can see we can do targeted biopsies of the lesion. So very, very useful in indeterminate cases where getting histological confirmation is critical. So returning to our case, this is the final cholangiogram from the lady that Hassan has already presented. And in her centre, it was discussed at the MDT. They are a team where they wish to achieve maximal drainage of the remnant liver, and they've elected to place a very, very precisely placed bare metal stent, which is flared just above the stricture, which is exactly what you want in this situation, and has achieved excellent biliary drainage. But that was as the outcome of a MDT discussion in a major tertiary centre, and then undertaken in that tertiary centre as well. So I'll pass back to Hassan.
Cool. Thanks so much. I mean, I think the key thing here is, where is this procedure done? Certainly in Merseyside, we kind of managed Merseyside in North Wales, and this was a patient from Wales. But essentially, if the patient's diagnosed with a presumed hilar cholangiocarcinoma, they're jaundiced, they need any form of biliary management, it comes to the centre rather than being managed in the district peripheral hospitals, and that is in conjunction with the MDT discussion. So that's where we were at there. So what about the role of any additional staging at this point? Has any people got any questions or comments about that? Brian, do you want to say anything about, would you, on the CT, it looks potentially operable, is there anything else you'd do?
I think we're just about to discuss it in the next slide, actually.
Okay. Okay. So the one thing that she didn't have is a PET scan. So that was probably predated some of the information about PET. But now, certainly in our centre, we'd be PETing most of these patients. But now we're moving on to how do we define resectability. So I'm going to pass on to Brian for that. You should have the control.
Thank you very much. Can everybody hear me? I should just start by saying that we've clearly gone against all MDT decision-making, and we've discussed biliary tract drainage before staging and decision about surgery. So we've gone completely against the guidelines that many people around the table have spent the last 2 years trying to develop. But never mind, let's move on. Hassan's asked me to very simply discuss what we as surgeons decide at the MDT. Hassan's already mentioned the fact that the MDT is a very pressurized environment and decisions have to be made quickly, which is a big disadvantage when we have very complex situations. And the other big deficit that we have in the MDT is that we usually don't have very much clinical information. We have very basic things, but often we don't know about people's comorbidities and their general health. So we often make decisions based on imaging rather than a holistic approach. So what do we do? My comments are very much for the non-surgeons, and I'm going to keep things very simple because I think the crux of MDT is that we should have lots of discussion. The first thing we want to know as surgeons is that there's not distant metastatic disease, because that would be an absolute contraindication to curative surgery. We can perhaps come back to whether it should be revisited. But how do we decide whether or not there's distant disease? Well, we want to exclude pulmonary metastasis spread to the lungs, and we do that with CT. And PET is also very useful for looking for distant metastasis. And from the point of view of distant spread in the abdomen, one of the common things that are overlooked by cross-sectional imaging like CT and MR is peritoneal disease. So in our centre, laparoscopy to look inside the abdomen with the camera is absolutely mandatory. So that's distant disease, but it's perhaps more complex and more challenging to decide about the local disease. Has the cancer spread locally to a point where it cannot be removed? And I've mentioned there about how we assess local spread. So the cancer is often spread from the bile duct into the liver and diffusely spread into the liver. The way of us deciding whether or not it has spread so extensively in the liver that it can't be cured by surgery is based on contrast CT and MR. And particularly there's a lot of interest in using special sequences of the MR that are gained routinely but can give information about whether or not nodules within the liver are cancer nodules or other benign nodules such as small abscesses which can happen in the same patient group. From the point of view of the bile duct, we want to know whether or not the cancer has spread up into the bile ducts further than you can resect, or further down the bile ducts further than you can resect, and we do that mainly by MRCP. And the other thing we need to be aware of is that sometimes these cancers skip around the bile duct, so they form a very tight stricture somewhere, and then in other parts of the bile duct they can spread further. So we've got to be on the lookout for multifocal cancers. And for that, sometimes we require the imaging that Chris has just mentioned to actually get direct visualization up the bile duct and look to see the bottom end, the top end, and the extent of cancer deposits. The other thing we'll come back to shortly is whether or not the cancer has spread into the lymph glands. That's the glands that can collect pathogens and also cancer deposits. And lymph nodes are very, very important, and they're very extensive around the liver. And as I'll come to discuss in a minute, they are very important prognostically. And we check for cancer deposits in the lymph nodes, mainly from CT and from PET scanning. Perhaps the most challenging thing for surgeons is about the extent of vascular involvement. And I'm not going to get into that because it's a very surgical and technical aspect. But if vessels are involved by the cancer, yes, sometimes you can scrape the cancer away from the vessels, but that's rarely curative. So often we have to resect vessels. And if you resect vessels to the liver, and particularly to the remnant liver, you've got to reconstruct them, as was mentioned earlier. And that's why a lot of the complex interventions that require vascular reconstruction are done within centres that have also transplantation expertise, because that's what we routinely do week in and week out, reconstruct vessels to the liver, the portal vein, and the hepatic artery. The last important thing that we have to try and decide at or after the MDT is, well, if we do a resection, if we remove the cancer and all the feeding liver, how much liver is going to be left? Because if we don't leave enough liver, then you die. And you require about 30 or 40% of your liver to be left behind to survive. And the liver regenerates and regrows, so as long as you leave enough, it will regenerate and you will go back to normal liver function. But it can be difficult to decide, and part of the decision-making is, well, if we change the resection, if we do this resection versus that resection, how much healthy liver will be left behind? And we want to optimize this residual liver volume. And particularly we want to know that it's healthy functioning liver, which is part of the reason why we drain the bile ducts, so that we know that that part of the liver is functioning and is producing healthy bile. So what's the decision making? How do we take all that information together to decide on whether or not somebody should be advised to consider surgery? Obviously there's their fitness for resection. It's a big procedure. We need to know that there's no distant metastasis. We need to know that it's technically resectable with a clear margin, and that's a very important thing, that if we can't achieve a clear margin, then it is likely to be a palliative procedure. It might be very good palliation. It might extend somebody's life and their quality of life, but the anticipation is that the cancer would come back. If we don't think there is enough liver left with our planned resection, so if we think that the cancer resection that would give the best chance of cure would not leave enough liver volume, we can modulate the liver volume by embolizing the contralateral lobe of the liver. And as mentioned earlier, that could be a portal vein or hepatic vein embolization, or possibly both. The crux of the matter is that these resections, because they're in the center of the liver and they usually extend out into a portion of the right and left side of the liver, usually require an extended hepatectomy where we remove the whole one side of the liver and extend into the other side of the liver. And I'll just show you very briefly what that looks like. These are just some schematic diagrams, and as you can see at the top here, this is a left resection, and you can see this is taking off the small left portion of the liver and the front of the right lobe of the liver and leaving this small remnant behind. That's what it looks like in cross-section. And alternatively, to remove the central portion of the liver, the cancer would be sitting here. To remove, an alternative option would remove all the right portion of the liver and extend into the left. So that would be an extended right hepatectomy, and this would be an extended left hepatectomy. And those are the two main options you have for a curative resection for cholangiocarcinoma. And which is best depends on the vessel involvement and your anticipated volume of remnant liver. So just before I hand back to Hassan, I'll just mention another part of the surgery, which is whether or not, as surgeons, we should remove all the glands around the liver. As I mentioned, these glands catch the cancer, and as you can see on this right side here, this is a study showing the prognostic significance of having cancer in your glands, and it very much increases the chance of mortality from the procedure. So metastatic disease into the glands is bad news. And because of that, surgeons often remove all the glands, or as many of the glands around the liver as possible during the procedure. On saying that, there is no randomized trial comparing that radical procedure, and it is not without risk. Removing all these glands around major vessels can damage the major vessels. So it's a non-evidence-based approach based on comparative retrospective studies of people that have had all the glands removed versus people that haven't. So retrospective cohort studies that have suggested it may be beneficial and it may increase the chance of cure. Back to Hassan.
Okay, cool. So we've been doing staging laparoscopies for about 15 odd years, since I started in Liverpool. So that was negative. Before I moved to that, so we didn't, at that stage, this was 2015, I think, do a PET scan because that data around PET wasn't available. I know Wan did an excellent paper around the role of PET. And so certainly on the back of that, we've been doing PET on all perihilar, intrahepatic and gallbladder cancers, certainly for the last 6-7 years anyway. So she had a resection. We removed the left side of the liver, bile duct, lymph nodes. We did resect the portal vein. We've done about 120 hilar cholangiocarcinoma resections in Liverpool, and a third will have had a vascular resection. We would now describe what we did to the hepatic artery as divestment, because there was tumour in contact with the artery and it was dissected free. So if you get onto the right anatomical plane, you can do that. This is certainly something described in pancreatic surgery. And so, despite the complexity, she was a young, fit patient, had good biliary drainage beforehand, wasn't cholangitic. She spent about 7 days in hospital, but she did go home with a surgical drain because of kind of low volume acidic leak, if I recall. That was the histology. There was node positive disease. Unfortunately, that's something we can't control. The thing that we can perhaps control is the resection margin. And as a surgeon, there's basically two margins, what I would describe as a true surgical margin, which is on the distal bile duct on the pancreas, the proximal bile duct, or the parenchymal transection margin in the liver, or this idea of the circumferential margin that the pathologists do report. That's something that I can't do anything with as a surgeon. This is how the tumour extends laterally. So that circumferential margin was positive. Anyway, so she did represent with a collection that was drained and subsequently went on to have adjuvant chemotherapy. Now, this patient was from North Wales, so she was treated by the oncologist in North Wales, who chose at that stage to go with cisgem rather than capecitabine, I would have thought, but that's a kind of local oncology decision. Perhaps when we get to the discussion later on, we can pick up on whether that was appropriate or not. So that's where we're at. So they've finished the chemotherapy, and the oncologist would have discharged the patient from the clinic. So what do we, as surgeons, do? Do we need to actually follow these patients up and do any further imaging? Would people want to comment on that? So any brief comments? Brian, what do you guys do?
Yes, we follow up all patients. As you should know, the frequency of follow-up should be aligned with the pattern of recurrent disease. So what we would do is have a fairly intensive early follow-up protocol, and as there's evidence for no recurrence, we would increase the period of between imaging, and we would follow up on CT just so that we have comparison. I think one of the problems that can happen is if people have a CT one place and then an MR somewhere else, and then somebody decides to do a PET, and then you've got a completely mess of non-comparative data. So it's good to have one imaging modality, same kind of scan, serially done to look for any minor changes.
Yeah, I mean, a couple of years back through the kind of cholangiocarcinoma UK forum, we did do a survey of all the centres. There was a lot of variability in what people did in terms of clinical follow-up, tumour markers, scans, etc. But I think now the BSG guidance has made that kind of side of things a bit more clear. Okay, so you're going to follow them up. How long for, do you think? Again, Brian, since you're the only surgeon there.
So I think it's very difficult because we're on the lookout not just for recurrence, but also recurrence that might be amenable to a further intervention, surgically or local ablative therapy. So what you don't want is to present with a recurrence that is large and unresectable, whereas at an earlier stage it would have been amenable to potentially curative retreatment. So for that reason, I think that you need to have a fairly intensive follow-up. As to when you stop the follow-up, I think it's very difficult because you and I have both seen very late recurrences that then become resectable. And you think, well, if I hadn't extended beyond 5 years, I would have missed this. So ultimately, we're trying to anticipate what's the likely growth rate and recurrence rate. But I think you certainly need a 5-year follow-up. And I must say, I would offer patients even a 10-year follow-up because I've seen many patients after 5 years that are desperately keen to have follow-up, and I don't think that we've got good enough evidence to say that they shouldn't have it. Yeah,
no, I agree, and I think, I don't know where Danny's disappeared to, but he's got data from this CAP-BILL study, and I think one of the things which would be interesting is to look at the cost effectiveness of follow-up up to 5 and up to 10 years, and we would follow up at least to 10 years. And then offer further follow-up if the patient feels comfortable with that. I think we wouldn't just kick people out. So anyway, the lady stayed well for a number of years actually, but then on imaging there was nothing to see, but then the CA99, which we're checking, started to kind of creep up to a slightly uncomfortable level. So we did a PET, and that shows this. So that's, I think we can see a kind of hot spot there. Again, I don't have the marker pen, but there's kind of red blob behind the pancreatic head, which is a kind of a nodal deposit, but nothing anywhere else that you could identify. Certainly no evidence of local recurrence in the liver. Remember, she had vascular resections, etc., so could have recurred in the hilum of the liver, but it's actually a nodal disease behind the pancreas. There you go. Yeah, go for it.
Can I just comment on that? I think there's two things that I think are interesting, worth of discussions. First of all, this is an area where you can get false positive PET scans with uptake round about the duodenum, so it's well known radiologically that this can lead to false positives. And the second thing is that, I know you're going to tell us the answer, but if I had seen that, I would be thinking of the possibility that this is another cholangio in the distal bile duct. That is another thing that would have crossed my mind, other than presumably nodal disease, which is what you're going to tell us about.
Okay, cool. Right, okay, we need to move on. Right, so we assume that this is kind of oligometastatic disease, and so what treatment can we think about then? So off to Ganesh. So you got your...
Thanks very much. So the patient has got what is described as oligometastatic disease. I'm not going to spend too much time because the definition of oligometastatic disease is a rapidly changing paradigm. Internationally, we would define it as less than 5 metastases, but in the UK, currently it's 3. But this patient has got a single solitary nodal relapse, quite a significant amount of time after the original surgery. And so I think there are a number of different options here, and this is where another MDT comes into play, and that is the metastases-directed therapies, which I will talk about. So ultimately, this is an old concept that is now relevant. So we know that oligometastatic disease has existed for some time. There are quite a lot of studies, particularly in the colorectal cancer and breast cancer, prostate cancer groups. But within HPV, within cholangiocarcinoma, it's something that's emerging, and it does represent probably a true improved survival outcome rather than what we call a lead time bias related to imaging. And what we need to try and do is optimize the treatment. I think this is where the points that were made by Shahid and David were really quite important. Because it's rare and we have a number of different options, an A versus B trial can be very challenging because the cancer itself, the biology of the cancer itself is different. And so fundamentally it is an MDT discussion to try and optimize the treatment within that, for that specific patient, and try and offer the lowest morbidity. We're likely to see a lot more oligometastatic disease with improved surveillance and imaging. So in terms of the evidence base, I'm very sorry for the busy slide, but this is really to highlight kind of the limitations. So we've got a single center retrospective series in a Japanese center looking at 232 patients. And MDT here is metastases-directed therapy, so apologies for the abbreviation. But you can see that in about 25% of patients, they did have some form of metastasis-directed therapy, and that varies from surgery, radiotherapy, microwave ablation, RFA, and there are other options available. As the technology improves, this is something that's going to increase, and those options increasing means that we probably need to optimize the way we research these treatments and therapies. And within this, they found that there were certain factors. The CA19-9 levels were predictive. If you had more than one organ involved, the number and the size of the tumor, the period which the recurrence occurred, so if it was less than a year, that was an independent predictor of, and that's survival after recurrence. And so they created these a variety of different algorithms to nomograms to try and predict results, but we can see this patient effectively would fall into the good prognosis group, and so an active management of her oligometastatic disease probably be indicated. Not that I'm biased, but this was the study on radiotherapy, specifically SBRT or SABR. Once again, very small volumes, very early follow-up, but within that group you can see that you are improving the outcomes by proactively treating these patients. Patients who had nodal or lung metastatic disease had a better outcome than perhaps patients who might have liver recurrence. And I think the whole thing about this is that we do know, and I've covered this in the early talk, that we can safely deliver these high-precision radiation treatments and SABR, but there are also a number of other metastases-directed therapies. For radiotherapy, keep coming back, it's all about the dose, sort of paraphrasing Megan Trainor there. But it's also, the other options, and I think one of the other things that we need to take into account is the durability of response. We can sometimes compromise these metastases-directed therapies. So, for instance, SABR's very straightforward. It can be integrated into any treatment paradigm. It's a short fractionation. Patients don't have too many visits, low morbidity. But it might be that that doesn't provide a durable outcome for someone like this, and perhaps something more radical. Maybe not in this patient, but if the node was resectable, then it may be that will be the better option. And the other thing is what happens if it happens again. What are the additive options for metastasis-directed therapies? Do we add in IRE, for instance, if it came back again? So it's very difficult, and the point about the research is important. So radiotherapy may be, and a lot of these metastasis-directed therapy are potentially tumor agnostic. And one of the things that's quite interesting is this EXTEND trial that's been developed by MD Anderson, and was presented for oligometastatic disease for PDAC, so pancreatic ductal adenocarcinomas, and it showed that patients who had some form of MTD plus chemo did better than those that were on standard of care treatment. So it might be that similar to the trial that you highlighted earlier, John, where you have a basket option, where you have a number of different options, although they are directed at perhaps biomarkers. So if they have a specific biomarker, for instance, if they may be suitable for immunotherapy, there's a huge amount of interest of using immunotherapy or even immunotherapy plus SABR or even HIFU. So this is an area of significant interest, and we need to evolve and develop these trials very quickly. And as highlighted earlier, you can develop a stratification process of how you might identify the best treatment for the patient. Ultimately, it comes back to using all the assets that we have, and how we derive that data is going to require, I think, prospective collection, and perhaps in the UK we may be able to do that collaboratively. But I think the most important thing, which we don't cover very well, is patient choice. What would the patient want in terms of the outcomes? Because we don't have a huge amount of evidence, and it's being able to counsel patients and getting them to understand how we can potentially improve outcomes. But it's also being able to highlight the uncertainty there.
Yeah, so they did have SABR, and I do take Brian's point. I mean, you could potentially have done an EUS and a biopsy to confirm that, but with a rising tumour marker, PET-positive disease, I think we just went straight for the local regional therapy. Remained well, but then about a year later, again, a kind of progressive rise in the tumour markers, and had evidence of now left-sided supraclavicular nodal disease, which is well away from the original site. They're well, performed status 0. The tumour was sequenced there, so I guess from the oncology point of view, does that mean anything to you guys? Is that something you could be wanting to think about giving something for, or yeah?
Well, I think first, the sequencing is not comprehensive, so we need some data. But anyway, it's another year, so we may maybe consider again a local regional treatment, but it's this second progression, CA19-9 increases up to 134, so probably we would consider a systemic therapy. But as I said, I would like to see the complete molecular
so this was
profiling.
again based on pathology report where I could only access some of this stuff, but so that's I think where we're at. We've come to the end of that case, so they're all systemic therapy. But that's it. Thank you. Brian?
Can I just be a bit provocative? I've got John Bridgewater sitting next to me, and if we had discussed that at our MDT, I suspect that he would have pushed for surgery. Did you discuss the surgical option? Because you didn't actually give us enough information to decide on whether or not it was resectable. You showed us a PET scan with activity. You didn't show us a cross-sectional CT, triple phase. If it had been nodal involvement that was within the head of pancreas and she would have had to have a Whipple's, I would have perhaps felt that that was a very high-risk option and that SABRE would be a reasonable alternative. But if that was a block dissection, 6 years after primary resection, local regional nodal disease, no distant metastatic disease, I must say I would have encouraged her to go down the line of resection. I'd be just interested in others' views and whether or not you discussed the option.
I think in that particular case, this patient's had a pretty radical operation for a hilar cholangiocarcinoma, a lot of dissection around that, the liver adhesions, etc. And you always have to balance the benefits and the risks and the morbidity. So this would have been a challenging laparotomy. Would you have got all the disease? Would you have had to do a Whipple, etc.? The fact is they relapse within a further year, well away from wherever any surgery would have been proposed. And ultimately, they probably would just be recovering from that operation when the further recurrence happened. I mean, the good thing is that SABRE is commissioned by NHS England for metachronous oligometastatic disease based on strong evidence, or as strong as you've got. So that was the thing we kind of went for. But I mean, the other scenario would have been if they had for example, an intrahepatic metastasis laid down. Would you have done ablation or radiotherapy or resection or whatever? So all these options are there. But I think the key thing here is that it's about keeping the patient in the tertiary system, continuing to follow them up and identify potentially treatable disease.
So another way of asking the same question that Brian has really is, would you consider the SABRE as curative?
It's a very good question. So yes, I think, well, it's tricky, isn't it? I think this patient's got metastatic disease, so the odds are they're going to recur. The tail for oligometastatic disease, where there's a survival-free, disease-free interval, is predominantly in cancers like colorectal cancer, prostate, breast, where actually if you offer them, maybe not breast, but certainly prostate cancer, where if you offer them targeted localized SABRE treatment, they go back to their pre-metastases survival. I think the evidence base for cholangio is weak, to say the least. So I think we're buying, I would probably consent the patient to say we're delaying systemic therapy, but that might be me being overly nihilistic, but that's usually what I say to patients with this sort of cancer.
Okay, I'm going to have to step in now because we've only got a few minutes, and I want to leave some time for questions. There are one or two questions coming through. Are there any questions from the floor? Please do come to the mics. And while you're thinking about coming to the mic, there's a question about if a patient is going to have upfront surgery, is it feasible to start with the staging laparoscopy, and if there's no signs of metastases, resect the tumour there and then and avoid too close surgeries?
Okay, do you want to go first?
Brian?
So often we would do that. The disadvantage is that if you find something that you're suspicious of, you've got to confirm whether it is or is not cancer. So if it's outside the liver and you see a nodule or several nodules and you biopsy them, you can do a frozen section, which gives you an immediate response from the pathologist. But the overall accuracy of frozen sections is not particularly high, so you could actually carry on with doing a very major life-threatening resection and then find out that it's a false negative on the frozen section, so that your biopsy has not been accurate enough. So that's the disadvantage of doing it, but we do sometimes, as long as we've counselled the patient accordingly.
Yeah, I think for me it's more of a psychological thing. So yes, there's the NHS cost aspect. You set aside a 3-session, a whole day's operating. You don't know whether this patient has peritoneal disease or not. You go in, you put a laparoscope in. Unfortunately, they've got peritoneal disease. The whole of the list goes down. So that's a cost loss to the NHS. But actually, more importantly than that, you've counselled a patient for a big operation, and they wake up and they've not had that. And that must be appalling, for that patient and their family. So I think we need to have as much information as we want before we put them through that. But I still will say to patients that it's not until we get in there that we really genuinely will know whether we can do this. And occasionally, despite the PET, despite the staging laparoscopy and the MR and the CT and things, we do find something that prevents us from going ahead. It's very rare, I have to say that, but I'd rather have all that information beforehand, and the laparoscopy can be done as a day case. They go home, I'll inform them and their family of what we found, and then the major resection is usually scheduled within 1 or 2 weeks of that.
I think that's very important to say, and I'll just reiterate something that Chris touched on. Even in the best MDT, and if you've got the most experienced people around, and decisions are made, but for the individual surgeon or endoscopist, they may be faced with an entirely new situation at the time of scoping or surgery, or even in clinic. A patient may say, "You know what? Actually, no, I don't agree." Right. So it doesn't. So the MDT is a guide, and it's not set in stone, and it's a fluid beast. There's a question to this mic.
Hello. Thank you very much for the very informative discussion. I have a question about metastasis-directed therapy. In this case, we had a patient with a metachronous recurrence. I wondered whether it was a synchronous oligometastasis versus a metachronous oligometastasis makes a difference in terms of the use of local therapies, including SABR, in the context of cholangiocarcinoma.
Yeah, so for SABR, it's not commissioned by the NHS, so won't be able to do it. I think it's a good question. I don't know that we have the evidence for that. I don't know if your surgical colleagues have got any other views. Would you? Depends on where the oligomet is, whether there be sequential.
Yeah. So local regional nodal disease, so nodes just round about the hilum and the cholangiocarcinoma, would not stop a curative resection. So as long as it was local regional disease, then that would be absolutely fine. So you need to have, obviously, the staging. You need to make absolutely sure that there is not any more distant nodal disease. And often at the time of resection, we would mobilize surrounding tissues actually to observe and whether or not there are any nodes outside the operative field, because CT and PET are not by any manner of means perfect. So it's always worth exploring in frozen section of any suspicious nodal disease that's out with local regional disease.
I'm just going to sneak in one final question from Benjamin, and this is really addressed to John and Lorenza. Can molecular profiling be a predictor of recurrence, of oligometastatic recurrence?
I'm not aware of any data in that sense. I don't think so.
No.
Okay. Okay, so I just want to thank Hassan and Chiara for chairing this into the excellent panel. Thank you very much.